Hi, everyone. Welcome to the Sports Docs podcast. On each episode, we chat about the most recent developments in sports medicine with experts from around the country. Today, we're coming to you live from the 10th Annual Arthrex Team Physician Controversies Conference in Naples, Florida. I'm Dr. Ashley Bassett.
And I'm Dr. Catherine Logan. The Team Physician Controversies is a 2-day conference focused on the treatment and the care of elite, collegiate, and professional athletes. It brings together experts from around the world to discuss case-based presentations. We're lucky enough to have the opportunity to have a lot of these experts in the studio today.
We're joined today by two outstanding guests, both of whom have extensive experience treating sports-related foot and ankle injuries. Dr. David Pedowitz is a professor of orthopedic surgery at the Thomas Jefferson Sidney Kimmel Medical College and is chief of foot and ankle surgery at Rothman Orthopedics. He's a consulting physician to the Philadelphia Eagles, Philadelphia Phillies, Villanova, St. Joseph's, and Drexel Universities.
And Dr. Josh Metzl, he's an associate professor of orthopedic surgery at the University of Colorado. He serves as the head orthopedic physician for the Colorado Ballet and is the assistant team physician for the Denver Broncos and the Colorado Rockies. Dr. Pedowitz, Dr. Metzl, thank you so much for joining us today. We're excited to have you.
Thanks for having us.
Thank you.
So today we're talking about sports-related foot and ankle injuries, particularly focusing on Achilles injuries and lateral ankle instability. We're going to chat about different surgical techniques to address these injuries, particularly focusing on how this has advanced over the years in terms of surgical approach and implant selection.
So we're going to kick it off with Achilles. So an injury that's been spotlighted in 2023 when Aaron Rodgers tore his Achilles just minutes into his first game of the season. Obviously, there's a lot of chatter about the accelerated rehab and recovery, in part due to the speed bridge technique. But before we get into that, we want to start big picture. So Josh, when are you recommending surgery to athletes with an Achilles injury?
Yeah, it's a great question. So any athlete that comes in with an Achilles tendon rupture, we first begin with kind of history and physical exam. You can consider advanced imaging like an MRI, which I think is helpful to determine the location of the rupture and help plan treatment. I think for the kind of traditional active patient who wishes to return to a high level of function, kind of return to their pre-injury level of function, I think surgery is well supported in multiple studies showing essentially better push-off strength, decreased re-rupture risk, and less atrophy. So in a very active patient population that we typically see in Colorado, I think that's the kind of discussion of why we favor surgery for these injuries.
Absolutely. So now we have a good understanding of who to operate on. Now let's talk about surgical technique, specifically how that's changed over the years in terms of approach and implant selection. So Dave, how has Achilles surgery advanced over the past decade and how has this impacted patient outcomes?
Ashley, I think, Achilles repair and thinking about an Achilles tendon surgery has changed drastically, probably more than many other surgeries which we do, to the point that when Josh and I were training, our mentors would have put an Achilles tendon rupture in a cast and had them be non-weight bearing for 6 weeks. And even if they did operate on them, they would be a large open repair, still non-weight bearing for a long period of time. And now it is massively accelerated to the point that we know that treatment is actually inferior to what we were offering these days, which is essentially a surgical repair with early active rehabilitation, early weight bearing to facilitate quicker recovery. So it's changed massively. So not just in terms of incision sizes and implants that we use, but even just the way we think about all of Achilles tendon repairs, period.
Yeah, I mean, you highlighted a couple of great points, as far as it's a quicker rehab, we're getting better outcomes. There's also lower wound complication rates with the new techniques, as well as better cosmesis. So lots of wins for the patients. And, we have lots of different options for how you do the repair, but we want to start with the PARS. So Josh, can you explain a little bit to the audience, what is the PARS technique?
Yeah, so the PARS stands for percutaneous Achilles repair system. And really, the idea of minimally invasive Achilles repair has actually been around since the late 1970s. There are publications looking at various techniques for minimally invasive Achilles repair. The challenge was that not all of those techniques were reproducible, meaning that the original authors would perform the study and then subsequent authors or investigators would not have the same results. So there were several attempts at minimally invasive repair that were the 70s, 80s, 90s, even early 2000 The really unique factor that allowed the pars or percutaneous Achilles repair system to have a big impact on how we approach these patients is the ability to create locking sutures in a percutaneous or minimally invasive way. That really is what allows these repairs to have increased strength compared to the prior generation of Achilles repairs. Also, to do this in a way that protects the sural nerve, which is really the sensory nerve that is most at risk during an Achilles tendon repair. So, to me, that's the advantage of using the pars technique, and we're able to do it through very, very small incisions, which helps to accelerate rehab and accelerate return to play.
Great. Yeah, so it sounds like pars really allows reliable suture passage within that tendon tissue, minimally invasively.
Yes.
So Dave, is your surgical technique similar? Do you do a horizontal incision, vertical incision, any surgical details?
So I do a vertical incision. I use the pars, but I use the pars mid-substance speed bridge. So if you look at, I think a minimally invasive approach to Achilles repair is advantageous. The reason I thought like that is because you could look at studies that show prospective randomized studies that are followed over long periods of time that show what look like equivalent outcomes between operative and non-operative treated Achilles. But when you if you look at the best study, it's from Scandinavia in 2019, which looked at minimally invasive, open, and non-operative treatment of Achilles tendon ruptures. And they said they were equal. But really what the author said at the end of the paper was, we can't identify who failed and who succeeded in each group. So we don't know which patients should actually be put in each group. There were people who did poorly and people who did well in each group. So from my perspective, if you can maximize the chance of push-off strength and minimize the chance of a surgical problem, meaning like a wound problem, then you really minimize re-rupture. And there's where the minimally invasive repair is so much more advantageous. I use a vertical incision because it can be extensile, right? It's hard to, I don't know what Josh does, but otherwise you have to make a Z if you have to extend it. But I use the mid-substance speed bridge because if you look at all the minimally invasive techniques that have been described over many decades, it has the highest pull-out strength.
Great. I think those are great points. And you'd mentioned sometimes we have to extend. So with any minimally invasive approach, there's sometimes the reason of why we need to extend and mini open a little bit larger. So Josh, what causes you to say, this needs to be more of an open procedure?
Yeah, great question. So not to disagree with my friend here, but I do prefer a horizontal incision. The reason why is because typically to achieve these great results for Achilles repair, like we're discussing, we have to maximally plantar flex the foot. We want to achieve maximum tension at the repair site. And I have found that when we plantar flex the foot, we achieve that maximum tension, it can increase pressure on the skin and it can make it more difficult for the skin incision to heal. So what I do is I do a horizontal incision at the level of the rupture. Then I pass the pars device. There's a passing device or a jig that goes within the peritoneum. And then I pass my sutures through the proximal part of the tendon. The times I think when that could be more difficult is if the rupture is perhaps more proximal, or sometimes actually the tendon just retracts up and you don't have great tissue proximally. If that's the case, instead of extending my incision, which I think is a very reasonable thing to do with a vertical incision, I actually just make a separate incision approximately 5 centimeters, and come through the peritoneum, protect the sural nerve like we talked about, and then you're actually able to get into the healthier tendon tissue. And I secure that either with the pars device or looking directly at it. And then I tunnel those sutures back within the peritoneum and I pass the pars jig distally. I really like the horizontal incisions. I think it heals in it's not just about cosmesis. I think there's much less tension on the skin.
It is also along Langer's lines.
And it's along Langer's lines.
Yeah. So those are really important points. Not only the surgical technique you pointed out, but also that sometimes you have to abandon that minimally invasive approach if it's in the best interest of the patient getting to that healthy tissue. So Dave, do you have any surgical pearls or pitfalls to share with surgeons for your technique, that minimally invasive speed bridge you were talking about, for surgeons who are thinking about adopting this new technique and moving away from the traditional open technique?
So I probably do about 3 of these a week, and I can't even remember the last time I opened one. So I don't think in my practice there's many situations where I think a standard open approach is more beneficial for the patient. If the sutures pull through or if it's terrible tendon, of course, these are exceptions. one of the questions that I get asked by residents and fellows is, can you make it too tight? So if you are maximally plantar flexing the ankle, like, can you make it too tight? I don't really think you can. If you look at the two variables which affect the chances of getting a good outcome from an Achilles tendon surgery, they are a young age and they are how tight the repair is. So those both correlate with positive and better outcomes. We can't change patients' ages, but we can change the tightness of the repair. And we know that surgically repaired Achilles tendon ruptures stretch out. And so I think the tighter, the better.
I would agree. And I think that's the same for many of the kind of tendon repairs that we do, distal bicep, or, I think they all kind of follow those same principles, that they would tend to elongate over time. So we want to achieve kind of maximum tension initially.
That time of surgery, absolutely.
Yeah.
And we want to hear from both of you on this, but Josh, we'll start. We want to talk a little bit about repair, construct, and implant options. We're going to start with the mid-substance Achilles tendon tear. So walk us through your choices there.
Yeah, so I think the real option you would have if you're going to commit to this kind of minimally invasive approach would be, do you want to do a pars construct proximally and distally, meaning suture to suture? The benefit in that context is that you are not placing any anchors within the calcaneus. So the probably the only downside to drilling into the calcaneus is that you could have a period of heel pain. And so if you feel like the tendon is healthy proximally and distally, then I think you can achieve a tendon to tendon repair and avoid any implants in the calcaneus. I think for me, I like to use the speed bridge construct. Sometimes the rupture is quite distal, and the amount of tendon that you are dealing with distally is very minimal. And so if that's the case, I really like to bypass that distal stump and consider a speed bridge construct. So I like speed bridge for a more distal rupture. My preference is still pars to pars because really with the minimally invasive technique, and especially a horizontal incision, we will call it the suture burden, meaning the amount of material that you're placing into the tendon itself, and the knots, really it becomes almost inconsequential because it's so minimally invasive. So I really like pars to pars when possible, and I use pars speed bridge if it's a more distal rupture.
Great.
I'm with the pars speed bridge completely because it's essentially a knotless technique. I don't like the suture burden at the level of the incision, which Josh was talking about. And people get excited about, do people have pain like anchor pain at the insertion site? And patients initially have that, just like they would have shoulder pain if they started doing push-ups after a labral repair, right? So but that completely goes away. And the anchors they've gotten smaller. They're smaller than they used to be. So I don't see heel pain as a big portion of the patients who get the anchors in the heel. There's some small techniques to probably decrease the incidence of it, but I haven't seen it to be a problem.
Great.
Yeah. Great takes there. So now let's shift to insertional Achilles pathology, which is a different separate clinical entity with different techniques and implant options. So Josh, can you walk us through your approach for insertional Achilles pathology and what implants you're using for surgery there?
Yeah, great question. So are you referring to more like Haglund's deformity?
Haglund's deformity,
so
exactly.
And I think as it pertains to athletes, this can present in a few different ways. Athletes can present with increasing heel pain, and that can be inflammatory change at the Achilles insertion. Haglund's deformity is really the bony prominence that can lead to fraying and degeneration of the Achilles undersurface. For the average patient that comes in with insertional Achilles pain, we always try conservative care, heel lifts, and a boot, and physical therapy, eccentric strengthening program. Really, in athletes, what we need to be concerned about is if the inflammatory change at the Achilles insertion leads to retrocalcaneal bursitis and potentially even an insertional rupture. That's really the complication that we're looking to avoid for a patient with Haglund's deformity. So the one thing we typically always avoid is corticosteroid injections because those can increase the risk of rupture. If we're thinking about surgery in these patients, I think there's two different approaches that I use. If a patient has a Haglund's deformity but no enthesophyte, meaning calcification at the tendon insertion, my preference is for a small lateral incision. You kind of lift up the edge of the tendon, resect the Haglund deformity, resect the kind of diseased undersurface of the tendon and the bursa, and then if necessary, a small anchor, maybe a fiber tack anchor, and then we close. And actually that usually is about a 4-month recovery for a high-level athlete. The other situation is an active patient who has more degenerative changes at the Achilles insertion, perhaps a larger enthesophyte, a large Haglund's deformity. For those patients, I prefer a posterior midline incision. It allows you better access to the tendon, and in particular, access to the calcification at the insertion. You can resect the Haglund's deformity, and then we use this speed bridge construct, which currently is a fiber tack anchor proximally and a 3.9 millimeter swivel lock anchor distally. And so I think that combination actually works very well. It's just slightly longer recovery because you really have to split the tendon and debride the bone.
I'm so glad you said that because I totally disagree.
Oh, man.
So I don't
we were friends.
We were friends.
Yeah.
So if you have like just the isolated bony prominence, I use a minimally invasive burr through a tiny incision, irrigating out all the bone paste, but really just making sure that whole retrocalcaneal bursal area, including the Haglund's deformity, is debrided using the burr. And it's really, it's such a small surgical footprint. I think patients recover really quickly from it. And I like it doesn't give you any other incisions that burn future procedures. But I agree with Josh. It is really how much tendinous involvement do you have? So if someone has a lot of tendinous involvement, I also do not do an open approach. I used to do it all the time, but that's an incision that people really dislike. It irritates all shoe wear. And if there's problems, there's not a lot of tolerance underneath it. There's no like significant soft tissue envelope. It's just bone. So I do the mid-substance speed bridge, the speed bridge construct distally, but I do it all through that minimally invasive approach where you take off the bony deformity, including the enthesophytes, using the minimally invasive burr, using a small scope to debride some of the tendon, and then reattaching it with essentially the larger fiber tacks with the swivel locks more distally. It's done through 4 incisions that essentially just look like 4 portal sites. I have really found that my patient's experience is so much better than the large open incision. I've really found that. I was a little skeptical. I'm not like I'm not like the earliest adopter of things, but if something makes sense, I do it. And I thought that this made sense. And I found that patients' experience is better with no inferiority in the clinical outcome.
Okay. Well, Dave, it might starting out to a surgeon who hasn't done that technique before seem a little intimidating. What are for listeners who want to try this type of technique, this minimally invasive, what are your pearls that you would share with them?
So I always tell people, so Roger Mann was my mentor. He always said, the operating room's not your laboratory, right? So I agree with that. And so, attending courses and getting comfortable and talking with surgeons who are doing it on a regular basis, there's nothing that speaks greater volumes than experience. And as we all know, with arthroscopy and anything that's minimally invasive, the more you do it, the more comfortable you'll become. So Arthrex has a large variety of courses that they offer throughout the year where surgeons are able to get really hands-on experience with experts in the field. And so I recommend people take advantage of that.
Great.
So to wrap up our conversation on Achilles now, we want to briefly discuss rehab and return to play. We don't want to go through it too much because we have a whole nother injury to get to. But as Catherine alluded to at the start, Aaron Rodgers' injury kind of captured the media attention. He returned to practice about 77 days after the surgery. And so we do want to talk about it a little bit. So Josh, when are you typically clearing patients to begin running? When are you allowing them to get back to practice? Is this like finite or is it based on patients?
Yes, such a great question. So I think just taking a step back, I do believe that there's a significant difference between return to play, which is what an orthopedic surgeon can clear a patient for, and return to performance. And it's subtle, but it's very different. So because someone goes back and is able to play does not mean they're at the level that they were previously. And so I think it's important to set realistic expectations for our patients. I do, typically for the average Achilles patient, I think, kind of beginning to increase activity at the 4 to 6 month range is very realistic after, really nice appropriate rehab protocol. There are certainly patients that I have had, especially in Colorado, hiking mountains and cycling at 4 and 5 months. And there are patients that may say that it took 9 to 12 months to really feel the comfort level to be able to do a single limb rise, which is really what it takes to begin running. So I think there's tremendous variability. What I typically remind our patients is most professional athletes, they're doing rehab all day, every day. So that's going to accelerate the recovery process. And if you have a day job like the rest of us, then that process may take a little bit longer.
I think setting expectations, as Josh was saying, is so important. If you look at expectations of the competitive athlete, whether they're professional or amateur, and you look at like an SAT score graph, right? The people who are really killing it or the people who did terribly, they're about 2 standard deviations above or below the mean. And that's where our patients' expectations are, right? Yeah. And so if they're asking for that, it's going to take a lot longer to get it. We typically, I think we would both agree, we don't let people certainly not run and jump before 3 months, because stretching out prematurely is a guaranteed failure of the technique, regardless of what you do surgically.
Yeah, I love that. And we've used that expression on the show before. There's a difference between return to play and return to performance. And especially in that high demand Colorado or the professional athletes, the expectations are high.
Jersey's high demand too.
Don't throw Jersey down.
And Philly.
That's right.
All right, we're going to shift our discussion to lateral ankle instability. So something that is very common, most often treated non-surgically. So let's start our discussion, Dave, with who actually needs surgery.
So, I mean, look, there's over 40,000 ankle sprains that visit an emergency room every day, right? So there's a lot of people who have ATFL pathology who need nothing, right? I really think that in the acute setting, it's hard for me to convince myself that that's really anyone unless they have other pathology, dislocated peroneal tendons, osteochondral lesions that you can identify. It's really the person who has failed non-surgical management, extensive courses of physical therapy, who are just getting instability. Even athletes, right? If they can't control their ankle, if they keep losing time from play, those are the people who need it.
Yeah, I think it's a great question. For me, the typical patient that needs a Brostrom procedure or ligamentous reconstruction is the patient with what we call functional instability, meaning their ankle gives way kind of on a daily basis or during sports. I also do think that there is a subset of patients with acute lateral ligament injuries. Now, each one's different, but if you are in practice and you see these every day, every once in a while, one will come in, it looks a little bit different. And my sense is sometimes these higher energy injuries, I agree that a trial of non-surgical treatment is not unreasonable. The problem is if you're a professional ballet dancer and we give you 3 months to rehab your ankle and then it still hurts and then you need surgery and then you spend another 4 months recovering, you've just missed a significant amount of time. So I do try to differentiate, and I think you kind of know it when you see it, but there are higher energy ligamentous injuries if a patient's fallen from a height, or we have dancers that come off a jump, and they're extremely swollen, extremely painful, can't bear weight. I do think that there is some benefit to considering fixing those in the more acute setting, just to prevent the kind of late sequelae and a more prolonged recovery process.
So now let's talk about that surgical technique a bit. So the Brostrom procedure, originally described in the 1960s, has undergone a dramatic evolution over the years. So Josh, can you talk about how this procedure has evolved to what we have now, and what are you currently doing?
Yes, great question. There's many different iterations. We could have a whole podcast only on the iterations of the Brostrom procedure, but essentially the original procedure was a ligamentous repair using suture of the lateral ligamentous complex, ATFL, with or without the CFL. Then there are modifications to that original Brostrom procedure, which is the Gould modification, where the extensor retinaculum is pulled into the repair to provide additional stability. I think that the challenge is, and I think for Dr. Pedowitz and I were both, doing these cases frequently, not everyone's tissue is the same. So you get in and sometimes actually the tissue is great and you could consider something more simple and straightforward. And sometimes you get into the case and especially in these patients with chronic instability, the ligamentous tissue is of poor quality. So as time has gone on, there's been many different kind of advancements in that procedure. There was these non-anatomic repairs that were really popular for a while, like the Crimson Snook and Watson-Jones, essentially rerouting of the peroneal tendons. Those provided excellent stability, but they caused subtalar arthrosis. And then there became a kind of thought process of, okay, if those are too stiff, then we could consider an allograft reconstruction of the peroneal tendons, which is actually quite useful, currently, as a bailout procedure. And then I think the other kind of big advancement is using anchors for these procedures, like suture anchors into the fibula. And then I think the most recent iteration and advancement would be internal brace, and thinking about, can we get enhanced stability that's an anatomic reconstruction that would allow us to rehab our patients more quickly.
That's the key difference, right? So all the procedures that Josh has explained, other than the rerouting procedures of the peroneal tendons, which cause other problems, they all work. They reapproximate and tighten up the lateral ankle ligament complex, but you cannot rehabilitate them early. You cannot. There are so many studies that show that they fail if you rehabilitate them early. You can wait a long time and they'll do fine. But there are real advances to allowing people to go back to work, allow people to go back to play, and the augmented repair, which is really, as Josh was saying, the latest iteration of what we're doing with the internal brace has revolutionized that.
Yeah, you actually are going right into what I want to dive into. So that's perfect.
Good.
So let's talk about that internal brace, that augmented repair. So what are you seeing as the benefits? It's return to play earlier. What else?
So if you think about the internal brace like a seatbelt, right? A seatbelt in a car, it allows you to do all the things you normally would do. You can still drive, you can talk on the phone, you can operate the radio, whatever you want to do. Maybe you shouldn't be on the phone. Hands-free, of course.
Just tell us when you're driving, okay? We'll get off the road.
But it doesn't do anything for normal driving. But if you were to get into an accident, it does prevent your head from hitting the windshield, right? So that's essentially the function of the internal brace. So if you are doing normal activities, the internal brace is essentially not doing much. But if your ankle is in a compromised position, it then gets tight and protects the repair. So this allows you to rehabilitate patients quite early when your repair has not healed, so that patients can really get back to play and back to productive lifestyles, whether they're competitive athletes or not.
Yeah, I think it's a great point because, essentially, if you immobilize for a more prolonged period of time, that original Brostrom procedure that we discussed, that's typically cast immobilization for 6 weeks. Well, then you lose muscle strength, you atrophy, you lose proprioception, and these can have an impact well beyond when the ligament repair is healed. So the idea that we can weight bear these patients early, get them into formal physical therapy, it has dramatic kind of downstream benefits.
So it sounds like that internal brace was a real game changer, but some surgeons may be starting to add it to their practice. So what pearls, pitfalls do you have in terms of tensioning, placement of that internal brace so that they avoid doing it incorrectly?
Yeah, I mean, I would just say I think the key point is what Dave said is that this is not a primary Brostrom. This is an augmentation of your Brostrom. So you still have to do either anchors to advance the ligament tissue or suture material, but you have to do something to repair the ligaments. My preference, my construct that I like to do now is really an anatomic reconstruction, and I use the internal brace in the talus, the fibula, and the calcaneus. And I have found, for me, that has really made a dramatic impact. These patients come in essentially taking off their boot and saying, my ankle feels great. And this is even at like 3 and 4 weeks, whereas previously that's really not what I was seeing. So I like the internal brace, talus, fibula, calcaneus. And I think I would encourage those who use it to consider maybe a more accelerated rehab protocol, because I think that's where you really get the benefits.
I don't go specifically into the calcaneus, like the CFL limb every time, but I do rehabilitate them quite quickly. Yeah. So my patients are often able to run at 6 weeks, which historically you would have been having a cast taken off at 6 weeks.
Yeah, very different.
Very different.
Well, Dave, Josh, this has been an awesome discussion, and we're so happy that you came on the show with us today. So thank you for coming.
Yes, thank you so much.
Thanks for having us.
Thank you for listening to this episode of the Sports Talks podcast, live from the Arthrex Team Physician Controversies Conference in Naples, Florida. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and on YouTube to stay up to date on all things sports medicine.